what about ALK fusions? There's like a dizzying number of drugs for ALK out there now. Leora, how do you choose? And one stops working, do you go to the next one? Do you go to the next one? What's your plan here?
Yeah, so we definitely have a wealth of options to choose from. Right now, the choice is fairly easy. The ALEX data is the most compelling data comparing alectinib to crizotinib. The progression-free survival, although we shouldn't be doing cross-trial comparisons with ALEX, does look better than the ALTA-1 data that was updated with the progression-free survival with brigatinib, and technically brigatinib is not FDA approved in the first line. So our first line treatment is alectinib, and that's what we've been using preferentially. I think it's really important to biopsy patients at the time of progression. There is the master ALK protocol that is open across the US, where based on mechanism of resistance, patients can be randomized to one of the many ALK inhibitors that are approved. A lot of patients on the second generation ALK inhibitors are going to have G1202R. Lorlatinib is the drug that is most effective in those patients when they have a G1202R mutation present. And so right now our first line therapy is alectinib. Interestingly, I'm not sure if you guys have seen this, but it more seems to be the ALK patients who are high PD-L1 expression than the EGFR patients. And it is definitely yes, you're PD-L1 positive, but now you need to wait 10 days till your molecular testing comes back because, you're young, you're a never smoker. And even if you're a smoker, you might have something that we can target with an oral agent. So long answer to a easy question, I guess. Alectinib is my preferred first line option.
That's very good. But Jacob, tell me, you don't have the master protocol open. You said, are you going to send a plasma test off to help you decide which TKI to use second?
That's a perfect transition or question for what I wanted to say, which is there's also the spacewalk trial, which is a remote plasma-based testing to also look at these fusions or these mutations. So there is a study actually for exactly the answer to your question and doing plasma-based testing.
So let's say you're not doing the trial and you send off
no trials.
The Guardant. How are you going to interpret the results?
Yeah, so no trials. I do think it's reasonable to send off plasma-based testing. But if you don't have an answer from that, then I think you're still looking at biopsy. Again, if you don't have anything else to target within there, then you're looking at chemotherapy.
And Jacob, just to comment on the spacewalk study, and because I know my patients have participated in this, your center does not need to have spacewalk open. The patients are being contacted directly by the spacewalk investigators and send their blood off, and they get the results so that we can use it. But this is information. We don't need to open a separate trial in order to get access to this sort of information.
That's right. This is a remote-based enrollment.
We do see these MET exon 14 splice mutations. I think, Josh, you want to tell me what you do for those patients?
Yeah, so any patient who has a MET exon 14 skipping mutation at this time, just like Leora's question, was complicated but also easy. We only have one drug that's FDA approved at this time. Crizotinib has activity in this space. There are multiple drugs that are coming out that seem exciting, seem to have a higher response rate, capmatinib, tepotinib, or some of them, and so there are more. And so once those drugs get approved, this question will get more complicated because both capmatinib and tepotinib have CNS penetration, whereas crizotinib does not. So I think I would be more likely to use one of those drugs when it is FDA approved, but at this time I do not have access to it. The critical thing about MET exon 14 skipping mutations to remember is that that mutation occurs in an intron. And so as a result, if your NGS panel is only exon-based, you are going to miss this. Even our panel at Penn, we usually don't see it on our mutation panel. We see it on our fusion panel as a MET exon 13 to 15 fusion. So that's MET exon 14 skipping. So it's something that we just need to be aware of as we're doing testing.
There's been a small series that was presented last year at I think, World Lung, showing some really remarkable responses to immunotherapy in these patients. Have other people seen exceptional responses with MET exon 14 splice mutations to IO, even in never smokers?
I have not, and there was another series that showed that those patients didn't respond to immunotherapy. So I don't know. These patients are more likely to be the smokers. We do see MET a lot in patients with the history of smoking. So maybe there's a lot of confounding factors there. But I've yet to see one patient respond.
Yeah, I mean, that series that you're quoting there, I believe, was out of France. And the series that showed it didn't work was in New York City. So I'm wondering if there's different patient populations between Sloan Kettering and France.